Great. And we have Office of Professional Regulation in, and Lauren and Jen. So thank you.
Thank you so much for having us. For the record, Lauren Hibbert, Deputy Secretary of State.
And Jennifer Cohen, General Counsel of the Office of Professional Regulation. Hello.
I want to apologize to the committee at the beginning, and this is why I asked for Jen and I to testify together. I have to walk out of this room at 10:20.
Okay.
But maybe we'll be done by then. I want to just because I may have to walk out of the room, I just want to respond really quickly to the testimony that Diva just gave, understanding the concerns they just raised. And then I'm going to turn it over to Jen to talk more about the OPR Sunrise process and the certification as we're setting it up. But I just really want to respond to the concerns that were brought up about opening the Medicaid policy and the increase of costs that Diva raised before you this morning. A couple of things, in our Sunrise process, Diva has been a really sturdy and steady partner. And so it's surprising to hear today that they think the certification, the voluntary certification of doulas will not work with Medicaid reimbursement. That's a new concern that has not been heard all the way through OPR Sunrise process, which was extensive, or on the Senate side. And so I will definitely need to understand that more. That is something that, again, has not been raised previously. The other thing is, while we understand the concern of opening the policy, and we do understand the landscape is somewhat different, the policy does need to be opened for other reasons too, and periodically. So I don't think it was anyone's expectation that this would be an immediate open, or that and that this would be something that would have to be balanced throughout the next couple of months and possibly even into the year because of the changed landscape. And then in terms of the cost, the testimony you heard on the increased costs, we would really urge the committee to think about the savings as well, because what our Sunrise report really outlined and found was that doulas save money. Yes, you pay for them, but they also save money time and time again, and particularly of the communities that I'm going to let Jen talk about. But they reduce the use of epidurals, they reduce C-sections, they reduce postpartum depression, and all of those things cost money to the system. And so we just want to make sure that the savings of doulas is also fully accounted for. And with that, I'm going to turn it over to Jen to talk about our Sunrise.
Thanks so much. And we're happy to talk about S53 regarding certification of community-based doulas. OPR fully supports this bill. And we support the idea that community-based doulas who are certified in Vermont will be covered by Medicaid because it is a critical support service for marginalized and under-resourced communities. And it's very important that those communities have that benefit. So as you know, OPR covers over 50 professions. We have over 80,000 licensees, and we offer 3 different types of credentials. We offer registration, certification, and licensure. And registration is a credential that we offer that requires no qualifications at all, and everybody who's in the profession, they have to register. Certification is a process where it's not mandatory for everybody in the profession, but it does require qualifications. So if you want to call yourself a qualified X, you have to get a certification from our office and you have to show that you're qualified. And then licensure is our kind of most stringent form of regulation, and that's where everybody in the profession has to have it, and you must show education qualifications. There's often an examination, supervised practice, and that sort of thing. So OPR studied doulas, and it was in the context of potential Medicaid coverage for doulas, and this body asked OPR to determine what form of regulation would be most appropriate in this profession. And based upon our study, we determined that certification would be the most appropriate form because we're not seeing harms out there from doula practice. We're not hearing about, we're not seeing documented harms from people practicing in the profession generally. What we're seeing and the testimony that this body heard last year was that, we have a maternal mortality crisis in the United States, that we have the highest maternal mortality rate of all developed countries, and that people from marginalized communities, people who lack access to healthcare are the folks who are having disparate, poor outcomes in the birthing process. And so we learned that in 2021, the maternal mortality rate in the US was 32.2 deaths per 100,000 live births, and that the disparities were largely based upon race and economic status. So, for example, the maternal death rate for non-Hispanic Black people was nearly 3 times the rate for non-Hispanic white people. Rural populations also have significantly increased rates of maternal mortality due to pregnancy-related complications, and Medicaid recipients are 80% more likely than privately insured folks to have severe maternal morbidity. Now, severe maternal morbidity, that's a mouthful, but basically that's unexpected outcomes of labor and delivery that result in significant short or long-term health consequences. Now, when you think about the Medicaid population being 80% more likely to have severe maternal morbidity, what that means is that there's more money being expended from Medicaid to pay for those treatment of long-term health consequences. So to the extent that we can have a tool in the toolbox that lowers the severe maternal morbidity, we should have that. That's going to not only help people and help people from marginalized communities, but it's also going to lower the cost of care in the short term and in the long term. So that's kind of speaking to what Lauren said a minute ago. In Vermont, 38% of all births are covered by Medicaid, and that's a significant percentage. Between 2021 and 2023, there were 8 perinatal maternal deaths in Vermont, and all of those folks were receiving Medicaid.
Can you say that again? You're going to send us this, right? I'm trying to keep up.
Oh, we did file testimony. I don't know if you've got
File,
it,
yeah.
written testimony. Okay.
Can you just repeat that?
Yes. So between 2021 and 2023, there were 8 perinatal maternal deaths in Vermont. And all of those individuals were folks receiving Medicaid. And I believe all of those folks were people in the postpartum time period within a year of giving birth. And I believe also that opioid and substance use factored in. So this is mental health after giving birth, which is something that as part of this bill would be covered, postpartum doula care for up to a year. And what we know is that doula care helps folks with their mental health, even though doulas are non-clinical support providers. Just having that resource, having that peer to reach out to that's helped you through the birthing process, and having those touch points with someone who can connect you to services, that's critical for folks in that postpartum, well, throughout the perinatal period, but particularly in the postpartum period.
Wouldn't these individuals also receive care if they went to a primary care facility?
They would receive care, but one of the things about community-based perinatal doulas is that those are folks from within the marginalized community, and they are peers who build relationships with the folks receiving their services over the course of the perinatal period. So it's a support person that is one of your peers instead of, kind of being in medical machinery without a peer that can support you through that process. And for marginalized people, that is critically important.
The other question I have, since we've just heard from Diva, it seems like the main issue is we could be opening up a can of worms here with the issue related to Medicaid. And I just wonder if we go ahead with this, we could lose, I guess, perhaps monies from the feds regarding Medicaid support. And I'm just wondering, how important is this bill and your program going forward when the state, could be in jeopardy of, losing future funding for our Medicaid programs?
And that's a very good question. I appreciate that question. As Lauren said, we need to connect with Diva and make sure that we're thoroughly understanding what the implications are. And we really haven't had an opportunity to do that. Because Diva was involved in our Sunrise process and we had meetings with them, and I'm sure it's because the landscape has changed, but this is kind of the first we're really hearing about this. So we need to know more. But what I would say is, and I haven't gotten all the way through my testimony, but when the United States has the highest maternal morbidity rate of developed countries, and that rate disparately impacts people of color, people who are from marginalized communities, and when there are tools that we can provide to folks so that it will improve their health outcomes in the short and long term, that's the right thing to do. And it's also going to save our system a lot of money. So I think it's vitally important to do this.
And I'm not arguing against that.
Yeah.
I'm just-
Yeah, I mean, throughout this Sunrise process, and I get a little bit passionate about it, but we learned how important this is. And let me kind of.
I have a question about back to the certification, voluntary certification process. What's your response to Diva saying that the voluntary certification process would be insufficient to meet the minimum federal requirements to get reimbursed? Have you heard of that before?
I haven't, and that surprises me a little bit because my understanding is that other states have certifications. And saying it's voluntary is other state Medicaid programs require certifications or qualifications in order to have coverage. So I'm not exactly sure what the impediment or what the language, there may be a little language issue in there. And I really want to talk with Alex McCracken about what that issue is, and maybe we can work on that through rulemaking once this legislation is passed, because we do expect Diva to be a significant partner in that process along with other stakeholders. Obviously, Diva will have to be involved in rulemaking.
It seems a little misleading because if you want to be a certified community doula, you must be certified.
You must be certified,
If
and
you want to be a doula that's not certified, sure, you can
correct.
choose not to become a certified community doula. But if you want to hold that title,
You
it's
have,
not voluntary.
correct.
You have to be certified.
Which is what I was saying. I think that voluntary word is a little bit tricky and there may be a language disconnect. So, because, if you want to bill Medicaid, you have to have this. So it's a little,
You can't bill Medicaid.
if you don't,
if you're not
Correct.
certified.
that's correct.
It's similar to a dietitian, right? A dietitian is a classic certification in OPR. I always like to say anyone gives you diet advice, most people do, but only a dietitian who's certified by the Office of Professional Regulation in the state of Vermont can give me dietary advice and have my insurance pay for it. So that's the equivalent model is, you can, if you pursue the dietitian certification, which is actually quite rigorous, then you can receive health insurance reimbursement.
So let me just continue through my testimony and hopefully that will answer some of your questions and give you a little more context. So
Actually, sure. Can I ask, first of all, I'm astounded, and I know it seems like a small number, but for such a small state, 8 in 1 year. Is this,
no, between 2021 and 2023.
okay, 2021, 2023. We think of, maternal care in the state of Vermont as being maybe the national, but that, and I'm wondering, because I believe someone who testified yesterday, do we know if any of those were suicides?
I don't know. I know that substance use disorder was present in most, if not all, and I know that mental health also factored in. So I don't know if those were suicides or not. I think there was I can supplement our testimony if you want a little more information. I think there was testimony last year about that. So I can look.
Thank you. Sorry.
That's totally okay. So in 2024, this body heard that testimony that over 60% of maternal deaths, and that's nationally, were deemed preventable by the CDC. Studies and data have shown that perinatal doula support substantially reduces C-section deliveries, low birth weights, preterm birth, epidural use, birth complications, postpartum depression, and anxiety rates. Substantially reduces, even though it's non-clinical care. Having a support person with you in the medical process to help advocate, to ask questions, to provide you education, that is a critical piece of support that folks from marginalized communities should have. Based on the legislative record, the intended regulatory purpose of the doula profession is to ensure equitable access to doula care for birthing persons in under-resourced and marginalized communities to improve health outcomes. So, there are plenty of people that get doula care, but those are folks that are paying out of pocket for that. So they're the ones that are seeing the better birth outcomes. And so increasing that access and having equitable access to such a vital support is important. Community-based doulas serve our most vulnerable birthing population. They are a subset of the profession for which specialized training and experience will demonstrate that they have the necessary competencies to serve communities experiencing disparate health outcomes that result from systemic biases, structural racism, poverty, substance use disorder, mental health disorders, housing insecurity, trauma histories, developmental disabilities, and the like. So there's specialized training that's needed for this subset of doulas so that they can provide the necessary peer support for folks in these communities.
Leslie, do you want to hold it or do you?
She just mentioned training and that's my question, but I'm happy to hold it.
Okay.
Okay.
Yeah.
Great. A tenet of community doulas is providing culturally congruent and competent services to birthing persons of shared cultural communities and languages. Community-based doulas are part of an asset-based approach to support underserved communities, meaning community strengths from within that community are used to give members of the community more control over their health. Whereas in a deficit-based approach, they're looking for solutions outside of the community to solve problems. So community-based doulas and certifying those folks will be a valuable market indicator of competency for Medicaid to cover these crucial services for communities experiencing those disparate maternal outcomes. I will say we did engage in a kind of a substantial process to study this issue and what the appropriate credential would be for doulas. And throughout the process, folks overwhelmingly supported certification. And they overwhelmingly supported the idea that we needed to be careful about right-sizing our regulation and not over-regulate. So we don't want to be over-regulating into areas where there's not a public protection need. Because as you know, OPR's focus is public protection. So we determined that certification of this subset of doulas would be the most effective and right-sized regulation to meet the goal that we're trying to meet here. So I got myself a little off track here, sorry. Happens when I start getting passionate about something. Oh, and the other piece is that we are hoping to build this workforce through this program also of community-based doulas so that they can provide culturally congruent and competent support within their own communities. So that means that we need to be careful and not put really strict requirements and expensive requirements for people to get education and go through. There are tons of national certification programs, but those can be really costly. So we need to make sure and not require something that's going to actually give us a field of professionals that is very small because they can't access the education necessary. So that's something that we need to make sure that we don't do in this process. The rulemaking process will be important here because that's how we're going to, that's the process by which we're going to determine with partners like DEVA what the qualifications need to be for the certification. And it will be important to recognize people's previous experience in the profession, because we've got folks who've been practicing in community-based settings for 20, 30 years. So we don't want to oust those folks from continuing to practice. So it will, we're thinking at this point, and we will need to develop this with partners, competency-based markers that folks have to meet, and having some sort of external certifying body that helps us figure out if they've demonstrated competencies either through experience or education or both. So upon passage, hopefully S53 will pass, and upon passage of the bill, we would need to establish infrastructure for the profession, which includes IT costs, stakeholder outreach, rulemaking, staff time, that sort of thing. So we estimated that cost at $25,000, and our expectation is if the bill passes, we'll have to immediately begin rulemaking efforts so that we can meet that July 1, 2026 implementation date, if that's the date that the bill passes with.
And it's my understanding that the Senate has that $25,000 in there and that it has gone through conference committee, and then that 25,000 remains.
Last I saw, it's still there. So
I think last I heard it was still there. And I think actually maybe that part of the budget has been closed.
I don't know.
Oh, okay.
Essentially.
I should go with
Yes,
this.
that's fine. Thank you, Lauren, for being here. That's right.
I'm happy to try to answer any questions. And if I'm not able to answer them, certainly happy to submit a follow-up written testimony to make sure your questions are answered.
Yeah, and do you would love to have your testimony in writing?
We submitted this
Oh, yes.
yesterday, I think. So
She hasn't gotten.
from Brian Mills. Okay.
Additionally, Kristen, could you post the sunrise report? I'm not sure if that's been posted under.
was yesterday.
Okay, all right. Brian,
Have you completed the presentation?
Oh, yes, I'm sorry.
No, it's okay. I didn't want to interrupt you because I know it's hard when you're trying to make a point and then people ask you about what you're about to talk about.
Thanks.
I just want to emphasize something you said about the relationship. Because in social work research, it's showing that for many years, it has shown that the most significant factor is not the treatment approach, it's the relationship. It's the bond. And so if if this is a way to provide birthing people, is that the term we use now, birthing persons? Birthing persons with a relationship to walk with them through the birthing process.
Exactly.
That's gonna like improve outcomes. I think that alone is worth it. So I just wanted, I heard you trying to emphasize, I heard that very strongly. So I just wanted to say that.
Agreed, and I feel that pretty strongly.
Leslie, so I appreciate your addressing the issue of competency. I was concerned yesterday, actually listening to the training options that doulas were doing, and it seemed vague, inconsistent. And I wasn't necessarily confident that there was a standard. So what I'm hearing you say is that you're looking at that. Is that-
Yes, and that would be part of the rulemaking process. Certainly, again, OPR's lens is public protection, and this is a really important issue in this profession in particular, because what we see is that if someone has doula care and they're from a marginalized community and they've enlisted the support of a doula, and that support is incompetent, then what you're doing is you're further alienating someone from being in the medical, I don't want to say machinery, but being in that medical process without support. And people kind of feel like if they have a bad experience, it alienates them from seeking help. And so that's what this is trying to solve, is that having an advocate to help you talk to a doctor when, you know, the doctor is someone who's been through medical school and has all this education and may not understand what you're trying to say and may not appreciate the information you're trying to give. And then if you have an incompetent doula with you, that's going to further exacerbate the problem that we're trying to solve. So we recognize that it's very important to make sure that people are competent, and our rulemaking process will address that. So thank you for that question.
Yeah, is there a national organization? I think that there was mentioned about a Vermont organization, but it was very new
Yes.
and hasn't really been established yet. So when we did birthing centers, it was a national organization, and they were, the competencies were going to come through that. Is there a similar doula that can establish competencies? Because I don't get where they're being established.
For community-based doulas, I think that's tricky. So there are plenty of national organizations that provide certifications for doula care. They're very expensive, I'll tell you that. And I don't think they get at that community-based training that designated agencies, for example, in the state of Vermont, are, you know, that cultural competence. I don't know that that's actually part of what those national organizations are doing. So I do think it will be important for it to be most likely a Vermont organization that does that. And just because the Vermont organization is new, and again, we've got to go through rulemaking and figure out all the ins and outs of this, but I would caution the idea that because it's new, we would be worried that they wouldn't understand kind of the competency that's necessary, because these are folks that have been, even if the organization's new, the practitioners have been doing this for a while. Yeah.
Has there ever been an example of something going through rulemaking and then not being approved?
Oh, that's a really good question. And I have to say, I've been general counsel at OPR for just shy of a year. And I am not aware of OPR ever having rules that ultimately were just like rejected by LCAR or through that rulemaking process. So I believe I don't actually know that that's a feature. I think rules might not get LCAR. Sorry, I'm not saying this artfully, but I'm going to give it a go anyway. So my understanding of the LCAR process is that ultimately, at the end of the process, if they don't like your rules and you kind of get that thumbs down, that doesn't mean that your rules, that you don't have those rules. It just means that if those rules are challenged in court, there's not the presumption that they are legally, trying to think of the right word. Yeah, or legally appropriate. So that's my understanding of if you don't get the LCAR blessing on the rules.
Thank you.
Yeah.
If you've mentioned competency and training,
Yes.
is there any, at this point, is there any training or anything that's being worked on that's being done now? I know a lot of other states have done this. So you're going like this, yes, there is?
And my understanding is that in Vermont, that is being worked on. And I know that one of the witnesses who testified, I believe yesterday, has been part of the creation of a community-based program that has had a lot of success. And there's training that is part of that program. So my understanding is that that is being worked on in Vermont already, even though this legislation hasn't passed yet. And nationally, I know that other states do provide that Medicaid coverage. And certainly in the rulemaking process, we would be looking more in depth at those other states and what they require so that, we can take the good bits of that and incorporate that here.
It'll be done.
Yes.
Yeah, okay. Thank you.
I actually had a kind of an unrelated but sort of related question.
Okay.
Just because talking about qualifications and things. So last year, I don't know if it was last year or the year before, we did certification around peer support.
Yes.
And peer support counselors.
Yes.
How's that going?
That's a great question. So that credential is not being offered just yet. I think we're supposed to offer that by July 1 of this coming year. And so we are at the very end of rulemaking in that process. And so that's a great example of, the length of time that it takes to go through that rulemaking process. But we expect that to offer that credential in July.
Yeah. And I was just thinking of other professions that we certify that, maybe there's not a pathway to get there, but in the rulemaking process,
Yes.
you set out the qualifications.
Yes.
Which this would be
Very
close to that.
Yeah. Sorry. That it would be
Yeah.
same thing.
Same thing.
Yeah.
All right. Oh, Alan.
I believe in the program. I have a concern with the funding.
Okay.
Okay, and I'm reading here, it says that the reimbursement rate qualified doulas an amount that are reasonable.
Yep.
I'd like to know what reasonable is. And adequate services for pre, during, and post. Is there going to be a time limit on post? Because some people might need the counseling, mental counseling for a long, long time.
I believe that's up to a year postpartum. And that's a great question because one of the wonderful kind of principles around community-based doulas is that they connect their clients with community-based resources. So if you have a community-based doula and they're helping you through that birthing process, and let's say you need more mental health support services, or you have housing insecurity, or you have food insecurity, that community-based doula will be competent in being able to refer you to other community resources to help address those challenges that you're having. So that's one of the really great things about community-based doulas. And then your other question about what is a reasonable reimbursement rate. And I think Medicaid has, or DIVA has that.
I was just going to mention, and Kristen, Alex McCracken provided testimony to Senate Health and Welfare, where they have already gone through the methodology and come up with the rates. And I'm gonna ask if Kristen can take that and post that on our website as well. Great question.
No, thank you.
Any other questions?
Any other questions? Great.
Okay,
Well,
great.
thank you so much for coming in.
Thank you so much. And yeah, feel free to have us back in if there's anything else.
So I think I really wanted, I think we're gonna take a break. So let's go off of live.